Okay, so this is going to be an audio slide on cancer. So it is probably going to be divided up into 4 sections so that I can actually give you guys a fair chance of understanding the information in increments. So these are just some of the objectives that we're going to consider. So we are basically looking at cancer from a whole bunch of different perspectives. We're looking at, what's benign, what's malignant, looking at factors that can cause cancer, looking at some of the nursing education and interventions and prevention measures that we need to consider. We're discussing the treatment modalities of cancer and just really talking about some of the main nursing oncologic emergencies that we may find. So by the time you're done listening to all of cancer PowerPoints, hopefully you'll get a pretty good understanding of all of this. All right, so what is cancer? So when we're talking about cancer here, we basically understand that there is some type of mutation essentially that happens. So in terms of the pathophysiology, that is the main thing. There's some type of mutation that happens and the cell's DNA is not what it needs to be. And there are a whole bunch of different things that can basically cause these different types of mutations. So some of them can be inherited or some of them are acquired mutations. So somewhere along your trajectory in your life, maybe you're living near a radiation plant or something, right? That would probably be like an example of an acquired mutation where it's because of the radiation maybe that you're exposed to. That's how come you end up getting mutations that happen in your DNA in your body. An example of maybe something like an inherited one might be something having to do with the BRCA1 or the BRCA2 genes that people with breast cancer may inherit. So supposedly all of us have BRCA1 and BRCA2 genes, and normally they're just normal proteins in your body that don't do weird things. They take care of you. If anything is wrong in your body, they fix the DNA. So they do good things for you normally. But so along the way, things go wrong and they mutate because of different variables. And the unfortunate thing is that if you have a mutation that happens, then your chances of getting breast cancer basically increase. And you can inherit like a defective BRCA1 or BRCA2 gene from either your mom or your dad. And that may increase your chances of getting breast cancer by a lot, and that can be as much as, in some books have stated that being as much as 50% likelihood that you may end up getting cancer, breast cancer in particular. So certain things you inherit and certain things you can acquire over your lifetime. All right, so regardless of how you got it, you end up with a cell that's altered in some way. So remember, cancer is proliferation, proliferation, proliferation. So the cell starts dividing, it forms a clone. Essentially what happens with that is that now what it does is it starts evading your normal cell growth. It totally takes over like the normal cell growth regulating processes, and it sometimes also takes over the normal defense mechanisms of the body. So it just alters everything. It just destroys everything. So it proliferates, and it's not helpful, but it's not a good thing that's going on in your body. It's invading your surrounding tissue, and the worst thing that can happen in terms of cancer is that it metastasizes. And how does it do that? It goes to your lymph node, it goes to your blood vessels, and then now it goes throughout your body, and it really just creates a lot of problems in your body. So that weird sentence there saying continue to proliferate, but there's no physiological demand. So normally you have cells that, when they grow, they're supposed to be helpful to your body. But these cells, they're not good cells. They're abnormal, they're mutated, and they're not doing anything helpful for you. So there's no good physiological demand as to why they're there. They're just bad, and they're just creating problems for you in your body. So your malignant cells, once again, uncontrolled cell proliferation, they're bad, so they're not beneficial. They don't recognize the job of the cell of origin, so they become undifferentiated. So remember how we had talked about stem cells before, and how we said stem cells are undifferentiated, but they have the potential to become differentiated. So when stem cells become differentiated, that means that they become specialized and they actually work in our favor. So they do a particular specific job that we want them to do. So that's a good thing, right? So we have these stem cells, they are undifferentiated, but they have the potential to become differentiated, which is good because we are going to put them to use for a particular task, right? Unfortunately, here with your malignant cells, they are just undifferentiated, so they're not helpful. They're not doing anything good, right? They mess up your growth regulating signals, right? They're just proliferating all over the place. The malignant cells are also capable of what is known as angiogenesis. So with this one, they're able to develop their own new blood vessels. These new blood vessels basically form, and now because they're formed, therefore the cancer cells can basically travel to many different parts of your body. So they've basically taken over. This is why we don't like cancer at all. They've taken over, they're cloning, they're developing their own blood cells, they're metastasizing potentially, so that's why we do not like cancer cells at all. In order for us to identify whether or not somebody has cancer, we have what are known as tumor-specific antigens, right? So this is basically a substance that's produced in tumor cells, and once the substances are produced, they basically can trigger your immune response in the host, right? So for our purposes, we look for tumor-specific antigens. So for example, if somebody is male and we want to assess whether or not they have prostate cancer, we are going to look for prostate-specific antigens. So we call that PSA. And so these are very specific markers. We're looking for a particular level of these PSAs to see whether or not that patient is at risk for getting prostate cancer. So in general, your PSA can be anywhere from 0 to 2.5, and the units are known as nanograms per milliliter. So it's ng per ml. So 0 to 2.5 nanograms per milliliter. If you do if you test a man's blood, you look at his PSA and it comes back to you and it's 0 to 2.5, then that's considered safe. That's considered like a lower number. You're not too worried about the patient having prostate cancer. If you do the same blood level and your PSA is anywhere from 2.6 to 4, the number 4, FOUR, then the doctor kind of starts paying a little bit more attention to you, because then they're monitoring you, asking questions like, is there a history in your family, all those types of things. What are you eating? Are you obese? We're going to start monitoring you closely. If the doctor does your PSA and the numbers come back and they're anywhere from 4 to 10 nanograms per milliliter, especially if the numbers are even, like, let's say 10, for instance, now your chances of you getting prostate cancer have significantly increased. So we're looking at those numbers as being suspicious. So 4 to 10, the number 10, ng per milliliter, we consider that to be very suspicious. And so now we're going to, maybe definitely maybe start doing biopsies or whatever we need to do to make sure to really assess whether or not you have prostate cancer. So by the simple fact that your PSA levels maybe are as high as 10, that may potentially increase your chance of getting prostate cancer by as much as even 25% in some patients. All right. So that's one way we can assess for tumors. The other thing that we can do is look at what is known as the CEA. So I think on your previous slide I didn't spell it properly, but it should be carcinoembryonic specific antigen. So this is a protein that they look for. Usually it's in decreased levels of anywhere from, it's supposed to be less than 2.5 nanograms per ml. And so for the CEA, we're looking for carcino-specific antigens. We expect them to be less than 2.5 nanograms per milliliter. So when we're looking at this particular value, we see increases in it in very specific types of cancers. So if somebody has something like colon cancer, or they have rectal cancer, or if they have cancer of the pancreas, even stomach cancer, or even breast cancer, this number may also become elevated. So especially if the number becomes elevated, then we're going to monitor those patients very, very closely. And we're going to suspect that potentially they have any of these types of cancers that I just mentioned to you. So once again, we don't know 100% what causes cancer in a lot of cases, right? So you don't care what the causative agent is, once again. So you have all of these different things over here that can cause issues in your target cell. So it could be viruses, it could be hormones, it could be radiation, chemicals, genetic factors, and unknown factors. We don't know. But something initiates this process on your target cell, and some type of mutation starts to happen. So now you have an altered cell, there's dysfunction in differentiation and proliferation. This goes on, and next thing you know, you have a cancer cell. And remember, the cancer cell is very powerful. It has the capacity to create its own blood cells. It has capacity to proliferate. So all of that happens here. So this is known as promotion. So now you're getting a proliferation of all these different types of cancer cells. And then obviously, if the process is not halted, maybe your immune system is not very strong, because ideally your body's supposed to protect you from any type of pathogens, any type of antigens in your system, right? So maybe you're lucky and your immune system is amazingly powerful. Maybe you'll be lucky and then it's going to end right here. Like it proliferates a little bit, but then your body kicks into gear and protects you. But most cases, if the cancer cells are that much stronger than your immune system, then it's going to progress, and you're definitely going to have evidence of clinical disease. And if you're unlucky, then this is going to spread and it's going to metastasize. So this is just an example of how the mutated cell ends up creating disease in your body. The particular process of a cell becoming transformed and becoming malignant, so that is known as carcinogenesis. So genesis is something new, so some type of transformation is going on. Carcinogens, just by definition, are any substances that cause cancer. And there are so many of them that we've basically kind of correlated to cancer. So some things that we know for sure are things like HPV, human papillomavirus. This can cause cervical cancer and head and neck cancers as well. So it's been implicated in both of these types. You do know that there's a vaccination right now for preventing cervical cancer, especially in women. So you can get that vaccine. People can opt not to take the vaccine, but I'm sure you've seen commercials where they're highlighting the need for you to get the HPV vaccine so that your chances of getting cervical cancer are reduced. And more in developing countries, you're finding a lot of incidences of cervical cancer. Like my country, Zambia, at one point was #1 with women getting cervical cancer. I'm hoping that they've since introduced the HPV vaccine and people are able to take it now. But that's a discussion that happens in different families, and they will make the decision whether or not to do it, right, after they've been informed. So other things that are implicated, so things like hepatitis B virus, right? So we know for a fact if patients have chronic hepatitis B virus, that, if people have hepatitis B, and it's a chronic type of hepatitis B, that they're more susceptible to getting things like liver cancer, right? Other things include things like Epstein-Barr viruses. They're implicated in lymphomas and nasopharyngeal types of cancers. So you want to monitor those patients closely. We have what are known as physical agents. So this includes things like sunlight, right? So they're implicated in skin cancers for sure. We have things like radiation. So sometimes you have one type of cancer and then you're getting radiation and for that cancer. So let's say you had I'm making this up, but let's say you had something like brain cancer, and for your particular type of brain cancer, they gave you radiation. Well, the fact that you're getting the radiation of your bone cancer makes you immunocompromised. It changes also cells in your body. So that also puts you at risk for getting other types of cancers, in particular, getting things like leukemia, getting things like multiple myeloma, getting things like lung, bone, or breast cancer even, right? So when you're getting treatment, that also puts you at risk for getting other types of cancers. If you have any type of chronic irritation or inflammation in your body, so inflammation is never a good thing, that can put you at risk for getting things like lung or pancreatic cancers. Tobacco usage for sure, so you can get things like lung and mouth types of cancers. So chemical agents are also implicated, so this is not a surprise for anybody. So tobacco smoke associated with a lot of types of cancers. You don't have to memorize the stats once again, but definitely know that tobacco smoke is an issue with cancers. And the fact that there's like 400 individual chemicals inside that tobacco that you're smoking, and that the fact that there's at least 60 known carcinogens within that tobacco that you're smoking. Other things include pesticides, asbestos, dyes, mercury. Any of those things are also things that can cause cancer. So here we're just looking at tobacco and looking at all the different types of components that are in there. So just look at all these funky things. I think the only thing that I knew for sure was that, okay, yeah, nicotine is bad for you, right? But I didn't know that all these other things are in there. You know, things like ammonia, things like methanol, arsenic, methane, acetic acid, butane. And these are crazy, weird things that you're essentially finding as being parts of the things that they use to make your cigarettes with. So I'm pretty sure now they've taken some of this stuff out and they probably make cigarettes without nicotine. I don't know. I'm not a smoker. I mean, people that smoke, you guys can tell me. But look at all these funky, weird things that used to be in your cigarettes, right? Things that you used to make batteries with, like this cadmium here. Things that you use in paintings. I mean, this is outrageous. Like, I have no idea who came up with this whole idea of smoking. Like, how did this start, right? I mean, I know that there are plants that you can smoke that people started with, but somewhere along the way, somebody said, you know, let's make cigarettes and let's make them profitable, and they put all these weird things, and on top of that, they wanted to make us become addicted to these things as well, right? Look at these weird things, like stuff they put in bug spray. Like, this is pretty crazy. So then there's the other piece where there is a genetic and familial predisposition. So almost every type of cancer has been shown to run in families. In particular, if you have two or more first degree or second degree relatives that have it, right, then your chances basically are going to increase. Most cancers tend to have an early onset in people usually younger than 50 years of age. And then you also have, we're going to talk about BRCA1 and BRCA2 genes later on when we talk about breast cancer as well. I'm sure you're familiar with, I think, Angelina Jolie, and I think the fact that she ended up cutting off one of her breasts because she had this hereditary component for BRCA1 genes. And so she opted to, I think because it ran in her family, because breast cancer ran in her family, she opted to have a preventative surgery. So even though you do that sometimes, though, it doesn't mean you never will get breast cancer. But I think if you, like, you know, your mother had it, where there's like this really huge family history, I could see why somebody would opt to do that to give themselves a fighting chance, right? And then the other piece of it is just hormonal agents are implicated in as to why people get certain types of cancers. So with estrogen, particular in women, that could be a factor. To maybe they're potentially getting things like breast cancer, and then in men, maybe androgens, androgens, maybe they're implicated as to why somebody's getting prostate cancer, let's say. So why are we getting cancer of the uterus, etc. So we start studying all of these things and trying to figure out, okay, what's going on hormonally that could be implicated. If somebody's on prolonged estrogen therapy, is that a factor, right? So we're just trying to figure out what are the different hormonal pieces that can trigger or stimulate cancer. Your diet is huge. So a lot of fats, a lot of alcohol, cured or smoked meats. I happen to eat bacon and I happen to love bacon. Unfortunately, a lot of the bacon has nitrates in it. And if you want to buy the organic, nitrate-free bacon, oh my goodness, for like maybe 6 pieces, it's costing you like $15. So my end goal and my end desire that I would like for my life is to actually buy a lot of land, which we've actually started. My fiance and I already did this. So we have like a ton of land in Africa, actually, because it was just easy to purchase the land at the time. And we have something like, I think it's 20 hectares. It's HECTARES, which I think is probably 40 acres or something like that. If you convert it. But my ideal life is literally just to live on a farm with nobody near me. We are also planning on doing that, of course, upstate. We're looking to get property here where I can grow my own food. I can have, if I need a cow for milk, I can have the cow there. I can have my own chickens, my own eggs. Like that to me is my ideal life, and that's how I want to live my life. So this is like a 5-year plan, and I'm hoping that my little measly CUNY salary somehow will help me figure out how to do this, because I just honestly do not trust the foods that I'm eating. I don't trust the environments that I'm living in. I'll probably keep my apartment in Harlem because it's worth keeping, but I'll probably rent it out to other people. But then I'm going to move out and live on a farm somewhere. With online teaching now, I could probably still teach nursing students from my home, right? So I highly encourage everybody to think of what you want your ideal life to be, because I think you can definitely do it and it's entirely possible. And I'm going off on a tangent here, but I've also gotten into listening to Dave Ramsey, who helps people get out of debt. And I would highly encourage you guys, once you get your degree, to start looking at your finances and start listening to Dave Ramsey. He's having a 2-week trial right now, which I know you guys can't do, but he's doing a 2-week trial that's free, where they teach you about having financial peace of mind and just trying to teach people never to get into debt in the first place, and then getting out of debt, because all of us have bills, we have families, we have kids, and it just gets so overwhelming. So anyway, but you're doing the right thing. You're going to school, you're advancing your degree, and start thinking about what's your ideal life, what do you want, because you can definitely make this happen within the next 5 years for sure. Anyway, so the other dietary pieces, stuff that's not good for you, so red meat, eating poorly, right, being obese, all of that is not going to help. And for sure, I think I've been thinking a lot since of the COVID crisis, where you get a lot of time to think too. I mean, you're stressed out, etc., but you also get time to think about what matters. And unfortunately, some people are drinking a lot. That's not helping their immune systems. Anyway, so if you can, just start thinking about your life in broader terms as well. So talking about food, there's also foods that are better for you, that can prevent you from ever getting cancer, or that can support you in beating cancer. So a lot of vegetables, broccoli, cauliflower, etc. And this is nothing new. We all know this already. The role of the immune system. So we've kind of talked about this already when we did immunity. So I really don't have to go into this too much. We know that it's to recognize and kill cancer cells when it comes to cancer in particular, right? There are surveillance cells that we have. And we know that we are looking for the tumor-associated antigens that are found on many cancer cells. And once we've identified those cancer cells, we are sending out our T cell lymphocytes. They're gonna release cytokines, and the job for the T cell lymphocytes is essentially to kill the cancer cells. So remember, this is part of your cell-mediated response, right? We're going in there, we're gonna kill them off. We're gonna call any other additional immune cells that we need, right? Because we want to stop this immune system invasion that has happened. We want to just attack it as quickly as possible and be okay. All right, so this is just a picture showing you what the T cells would be doing, right? So there's a cancer cell in your body, and there is the tumor-associated antigen right here, right? So they've spotted it. So our T cells come in, they block it, they kill it off. That's what they're supposed to be doing to protect us. We're going to talk about detection and prevention, and there's three main ways of doing this. So it's primary, secondary, and tertiary, and some of this should be familiar to you already. So for primary prevention, the main thing with primary prevention is before the disease has happened, so before you've gotten the cancer, so what do you care about? So you never want to get cancer. What are you going to focus on? Patient education. That is the thing that you're going to be focusing on, patient education, right? So you want to reduce the risk of the disease. So it's all about health promotion. It's all about risk reduction strategies, right? It's lifestyle modifications. It's all about a healthy diet. We want to basically prevent you from ever having cancer. So there's a statistic here that's been given for you that at least 75% of all cancers are related to lifestyle and environmental causes. So there's something you're doing in your lifestyle, maybe it's your environment, you're near a radiation plant or something, that's why you're more at risk for getting the cancer. But the main takeaway under primary is prevention, risk reduction, health promotion. This is before you've gotten the cancer. The other type of prevention is known as secondary prevention. So here, the primary goal is that we want to screen, and we want to detect the cancer as quickly as possible. So maybe if you're doing things like screening, you're getting funky symptoms in your body. Maybe you have a family history, let's say, of breast cancer. So you know that screening for you is incredibly important, right? So you have to go the extra step. Maybe you were doing your breast self-examination and you felt a lump, right? So there's weird things that are happening here that are making you think something is wrong. So you want to go the extra step to basically say, okay, what are we going to be doing here? We want to maybe draw blood so I can see what my PSA levels look like. I'm going to do some CEA, right? You're doing some type of monitoring, a little bit more aggressive. It's not just teaching now, right? You're suspicious that something is going on. So the whole purpose of screening and early detection is you want to decrease cancer morbidity and mortality, right? With screening as well, you want to reach populations without insurance or those without transportation. So this is really what a lot of public health is about, right? Public health services, like trying to reach all those populations that ordinarily wouldn't have healthcare access, right? So what does screening or secondary prevention look like? So this is where you're doing your mammograms, right? This is where you're doing your PSA blood tests, right? Because you want to see how much is in the blood, right? How much of those antigens are in the blood. This is where also where the man is getting a digital rectal exam, right? And when they're doing the digital rectal exams, they're able to feel, the doctor is able to feel for any abnormal lumps, or if the prostate is hard or strange in any way. So you're going the extra step here. And this maybe now you are doing in men that maybe are over 50, because there's a correlation that the older men get, the more at risk they may be for prostate cancer, right? The prostate may start misbehaving, for lack of a better word. So it's important now that you're 50 that maybe they start checking your prostate. So they're going to start doing digital rectal exams, right? Because they're not going to be doing DREs in little boys who are 10. It doesn't make sense, right? So anyway, main takeaway is a secondary prevention. You're kind of, wanting to prevent things from getting worse. You wanna detect, early detection, early detection, early detection. How are you doing this? So it's mammograms, blood tests, or manual exams such as digital rectal examinations. The tertiary prevention. So you're still focusing on monitoring and screening, but really tertiary is after the fact. So you're preventing the recurrence of the cancer. So this is usually after you've had a cancer and now you don't want it to come back. So you're basically trying to be very diligent in terms of your diet, making sure you're getting your screenings done so that they can catch it early, if anything. So you're also, maybe you've gotten treatment, right? Maybe you had radiation. So you're also now screening for secondary malignancies or metastases or any of that stuff. You're looking at you're looking out for things like lymphomas or leukemias, because some of these conditions are directly related to the fact that you've gotten some type of treatment. So now you're more susceptible to getting other types of cancers, right? So all of these would fall under your tertiary preventions. Your cancer diagnosis is going to be based on the assessment of physiologic and functional changes. So you do need to do very extensive testing if cancer is suspected. You want to determine the presence and extent of the cancer. You want to look to see whether or not there's any possible metastases. You want to see if any of your nearby tissue or body organs are involved in any way. You want to do biopsies for sure. You want to see if take the cells and look at them for analyses, and you want to stage and grade the tumor staging, right? So biopsies come in different ways. So they can be described as excisional. So if they're doing an excisional biopsy, it's usually for small or easily accessible tumors. Excisional is also further subdivided into local and radical. So under excisional biopsies, they also further subdivide this category into local and radical. And I have another slide later on that discusses this. So in general, excisional used for small, easily accessible tumors. Sometimes the surgeon can remove the entire tumor and the surrounding tissue. And the whole point why we're doing this type of biopsy is that we're trying to prevent seeding in surrounding tissue. So seeding essentially is just like growth or planting, right? So you have seeds and you do seeding, you throw them into your land. Well, they go everywhere, they spread, right? So you get a bigger crop. So same exact thing here. We don't want a bigger crop of cancer cells, right? So that's why we're cutting them out so that they're not metastasizing, essentially. So we can do this for different types of cancers, right? And we want to prevent seeding into surrounding tissue, so like your skin, your breast, your upper lower GI, or upper respiratory, right? So we don't want that to happen. Biopsies can also be described as incisional. So for this, it's when the tumor is too large, right? It's too big to be removed. So what they're going to do for this one is they're going to get a bigger piece taken out. So it could be a wedge of tissue from the tumor is removed, and then it's sent to the lab. They look at it closely. So then they're going to analyze it, and they're going to stage it. They can also do what is known as a needle biopsy to look at suspicious masses that are easily and safely accessible. So they can do needle biopsies for either breast, thyroid, lung, liver, or kidney tissues, right? And then they're going to do the same thing. They're going to analyze it, and then they're going to stage it. So Obviously, this is a needle, right? So it's smaller than the wedge that you would do in the incisional, all right? So it's a needle biopsy. So that could be an example of a needle biopsy here. Staging and grading is incredibly important. So I am going to refer you to page 335. You are going to look at that chart. You are going to have to be able to tell me what you think the stage is for a patient. So I'll give you, let me just go ahead for a minute. You may be given something like this, like your patient is admitted and they've been staged as T4, N3, and M1. You have to be able to tell me what that sounds like what type of tumor. Is it good or is it bad? Not that there's any type of cancer that's bad, but you have to be able to tell me what the staging suggests. Is it in the early phases of the disease, or is it in the later phases of the disease? So you're going to go to page 335, and you're going to look at the chart, and you have to be able to read what the staging means. So the T basically stands for the primary tumor size. The N lets you know how much lymph node involvement there is, and the M lets you know whether or not there's any metastases, right? So it's pretty easy actually. The minute you see that there's any type of lymph node involvement, whether it's 1, 2, or 3, then you know that the cancer has basically metastasized, and that's bad, right? It's spreading because the lymph nodes are involved in some way. The minute you see whether or not metastases has happened, then you know that that's bad, right? And the tumor size just lets you know how big the tumor itself is. So on page 335, so remember you have T and M system, right? So under the T, under the primary tumor size, there's a couple different possibilities that can happen. So the patient can either be TX, TO, TIS, or T1, T2, T3, T4, right? Anytime you see an X, let's say that they diagnose your patient as being TX, then that means that the primary tumor cannot be assessed, right? So it may be there, but they cannot assess it. They're not 100% sure what's going on. So that may be the kind of patient that they send home, but then they tell them to come back again because they couldn't assess anything. If they diagnose you as T0, that means that there's no evidence of primary tumor. Then there's definitely no evidence, they can't see it. It doesn't mean that you will always never have one. You may later on, but right now they're diagnosing you as T0, so there's no evidence of primary tumor. If they have you as TIS, that means there's a carcinoma in situ, SITU. So they're seeing something there, but it's just kind of sitting there. Maybe it's not malignant, it's benign, but there's something there, right? And then when it's T1, T2, T3, or T4, that's just the size. So obviously T1 versus T4, T1 is smaller than T4. So T4 would be considered like a really, really big tumor. Under lymph node involvement, you can either be NX, N0, N1, N2, or N3. So NX, anytime you see X once again, they cannot assess whether or not there's regional lymph node involvement, right? So NX would be regional lymph nodes cannot be assessed. N0 would be no regional lymph node metastases. So you want N0, right? You don't want them to say NX because then that just means they don't know, right? But if they tell you N0, then you know there's no regional lymph node metastases. If they give you N1, N2, or N3, obviously N1 means just one lymph node is involved versus N3 meaning that 3 lymph nodes are involved. So now there's metastases there for sure, and this thing is spreading. For the metastases, so it can either be MX, which means distant metastases cannot be assessed once again. So that's not necessarily a good thing. It just means they can't assess it. Or it can be M0. M0 is what you want. There's no distant metastases at all, right? or it can be M1, which is distant metastases. So you definitely don't want M1 because now there is metastases. All right. So this is just one way of describing staging for a sample that they've taken. The other piece of it is by either saying like breast cancer is stage 1 through stage 4. For your purposes, I would expect you to know that if it's stage 1, that's not as bad as having stage 4. If somebody has stage 4 breast cancer, that means it's pretty advanced. There's definitely metastases going on, etc. But for your purposes, I need you to be familiar with the TNM system. So for this one, it was a large tumor. For the example we're given, there were 3 regional nodes that were involved, and we had distant metastases. All right. So spend some time on page 335, please, and really know that, because you will definitely be getting a question. So this is what I was talking about in terms of the stages of breast cancer. So this would be considered stage 1. This is stage 2. This is 3 and 4. So here you're seeing that just much more of the metastases has happened, right? Here you're just seeing this one here, and everything else is okay. The lymph nodes haven't been affected yet, but in this one you're seeing how it's spreading out more. And then we are going to talk about management, but this is going to be in a separate slide.